So thanks everybody, and thanks Dr. Saad for preparing this for us. We really appreciate it. So the first patient is a 46-year-old male who had swelling in his left eye since he was a child. Although over the last 2 to 3 years, the swelling increased and his visual acuity worsened. This is a picture of him. He had left eye lateral gaze deviation and proptosis, but was otherwise neurologically intact. Well, his visual acuity was worsening initially at the time of this presentation, so he got a CT of the orbit as well as an MRI. Let's see, I'm just seeing which residents are on. Turkey, sorry to put you on the spot. Can you tell me what you see? Okay, I'm not sure if he's on. Christian, I'm sorry. Can you tell me what you see?
Yeah.
I can hear you. Yeah.
Yeah. I mean, there's a contrast enhancing lesion in the orbit. It seems kind of diffuse. I mean, it doesn't look very discrete. I mean, you see there's enhancement outside the orbit also in the almost in the temporalis muscle, and then also some line of enhancement in the left middle fossa. Just trying to look around for a sec.
Yeah, exactly. So, with the orbital component, is it intraconal or extraconal?
I would say intraconal.
Okay. Yeah, I guess it's kind of encroaching. I think it's like primarily extra, like kind of pushing inwards on the rectus muscle.
Okay.
And then would you say that it's like bulbar, retrobulbar, or apical in the orbit?
I guess retrobulbar. I wouldn't say apical.
Yeah, that's right. And then those names kind of help you narrow down the differential diagnosis a little bit. And then do you know what this is?
Maybe the lacrimal gland. I don't know. You're just seeing enhancement of it.
Yeah, that's right. So when you see orbital things, what big like classes of like diagnostic categories are there typically?
I guess neoplastic. There's infectious. Theoretically, you could have a hemorrhage, but that doesn't look like this. You could have inflammatory, like sarcoid. What else?
Yeah, those are the big ones. I just wanted to get at, like, it's not necessarily just a tumor, like it could be an inflammatory process.
Mm-hmm.
Are inflammatory processes usually bilateral or unilateral?
Bilateral.
Right. Although some are not, as we'll talk about a little bit. So this guy got a excisional biopsy by oculoplastics. This is what I was talking about. So when you're thinking about lesions of the orbit, it's helpful to kind of break it down into broad categories, and helps you eliminate certain categories and focus on others. So there's bulbar lesions, retrobulbar lesions, and apical lesions. These two slides I borrowed from Dr. Morcos' excellent Miami tumor symposiums talk. And then you can also think about whether or not the lesion is intraconal or extraconal. If it's extraconal, is it intradural or extradural? And if it's intraconal, is it, in comparison to the optic nerve, is it medial, lateral, or central? Because that can help determine the approach that you need to take. And then here, this is a great figure that kind of breaks down the differential diagnosis by location. So this is kind of the area of where that lesion that we saw was. sort of, if you look at the normal lacrimal gland, it's kind of symmetrically there. So things around involving lacrimal gland, pleomorphic adenoma, carcinoma, lymphoma sort of in the area. And then all these non-neoplastic orbital lesions a lot of them are inflammatory. And a lot of the inflammatory lesions are often bilateral, but there's something called orbital pseudotumor, which is an inflammatory process, and that's usually unilateral. It's actually the most common orbital inflammatory lesion. And then sarcoidosis is also one to not forget. And finally, metastases can kind of arise from anywhere. So as I mentioned, this guy had a excisional biopsy, although the lesion rapidly recurred 4 months post biopsy. He had this MRI. There's, sort of in a similar place in the orbit, and also looks like there's some dural thickening here, and involving the bone as well. So he had a combined surgery. He had a PET scan which showed a hot lymph node. So Dr. Sarji did a neck dissection and also a parotidectomy. Apparently, that's what you do with these lesions that are when they're in the salivary glands, and we'll talk about more what this is in a minute. But with Dr. Morcos, remove the involved bone and any involved dura, and then he had an orbital exenteration. He had very poor vision, almost no vision when he went to surgery the second time, so they felt that they needed to exenterate the orbit for disease control. And then we can talk, Dr. Saad, if you could talk about the pathology.
Yes, let me share my screen so I can use my arrow if it's okay. No?
Yeah, yeah, absolutely.
Okay, thank you. Okay, so I was able, the orbital tissue went to Bascom Palmer, which I wasn't able to retrieve, but I'm gonna show you the skin lesions around the eye and also the sphenoid wing tumor. So this is a very good opportunity here to show you, it's a little bit irrelevant to this case, but to show you what the sun does to the skin. You see this, what we call solar elastosis, is basically severe damage to the fibrous tissue that is in the dermis, and it looks bluish, hyalinized. And here you have this tumor, which on higher magnification, you can appreciate the presence of what we call palisading at the periphery of the nests, and also clefting. So this is a basal cell carcinoma, and these are two main features, the palisading at the periphery of the nests, and also this cleft or clear space that is between the tumor and the adjacent tissue. And this is the sphenoid wing tumor, same tumor. These are minor salivary glands, sun damage. And this is the tumor, which at low magnification is composed of multiple nests, and on higher magnification, similar to the one that is from the skin, peripheral palisading and this clefting or clearing around the nests. The bone was also involved, and it's very tricky because the foci of tumor were microscopic, basically. So here we're looking at the bony trapeculae, a little bit of bone marrow fibrosis, which is not a big deal. And then you have these microscopic foci of tumor, which on higher magnification and also by immunostain confirmed that this is indeed a basal cell carcinoma. I'm sorry, I don't have the left orbital contents, which is the eye, because Bascom Palmer will not release it to us. But this is a basal cell carcinoma heavily infiltrating into soft tissue and bone.
So at the time of the initial biopsy, this was a carcinoma ex pleomorphic adenoma of the lacrimal glands, and I thought I would just do a discussion about this just because it's such a rare tumor that we don't see that often. He also did have a basal cell, but I just wanted to go over this entity because I had never heard of it before. Also known as a malignant mixed tumor. They're extremely rare. They're the second most common malignant lacrimal gland tumor. And it contains both a malignant component as well as a pleomorphic adenoma component. There are a lot of different types of carcinomas and adenomas of the lacrimal glands out there. And carcinoma ex pleomorphic adenoma should not be considered a standalone diagnosis because the type and the extent of the carcinoma component impact disease management. The malignant component is typically either epithelial or myoepithelial, and the most common epithelial component is like salivary duct-like epithelial carcinoma. And then they can occur de novo or represent an abrupt change from a pleomorphic adenoma. And then they are typically judged by how invasive into the pleomorphic adenoma capsule the carcinoma is. Either non-invasive, like respecting the capsule entirely, minimally invasive, like kind of budging in to the capsule less than 1.5 millimeters, or invasive, more than 1.5 millimeters, invading the capsule. And having a disease focus beyond the capsule is a poor prognostic sign. And invasive disease confers a 70% risk of recurrence and a 60% risk of tumor-related death. So these are pretty nasty tumors. Treatment involves treatment is dependent on the invasiveness of the tumor and can determine either lesional excision versus orbital exenceration. For invasive tumors, for tumors with perineural invasion or with malignant transformation following recurrent pleomorphic adenoma, then it's recommended that the patients get postoperative radiation, and in some cases, trastuzumab has been used, although again, there's just not a lot of data because this is such a rare clinical entity. Okay, so let's just see if anybody else is logged on. Eva, are you there?
Yeah.
Awesome. So this is a 33-year-old male, originally from Haiti, although he's been living in Miami for 8 years. He had a first-time seizure while driving. No other past medical history, neurologically intact, although during his hospitalization, he was found to have an incidental subsegmental pulmonary embolism. So after his seizure, he got an MRI. And can you tell me what you see?
It looks like it's a ring-enhancing lesion that's right below the corpus callosum. Oh, can you go to that other slide that you had too?
Mm-hmm.
It looks like it doesn't diffusion restrict. It's like the same intensity as CSF, so probably it's like a cystic appearing lesion.
Yeah, I agree that there's a cystic component. Do you have any what's your differential diagnosis?
The differential is given like the ring enhancement. It's probably high-grade glioma. I guess some other things, it could be, yeah, or maybe like some like abscess or like neurocysticercosis.
Okay. Whenever I see a ring enhancing lesion, I always kind of automatically, in a patient that's not immunocompromised, I automatically say high-grade glioma, metastasis, or abscess. And then how do you distinguish radiographically between those three things based on the shape and thickness of the enhancement?
I think that low-grade glioma was it has like a thicker ring enhancement, and then for metastasis, it's a more like regular, like the circle. It's like circular, and then like not, it's either has a lot of vasogenic edema or a little bit of vasogenic edema surrounding it. And then for abscess, it's like an irregular ring enhancement with like a lot of vasogenic edema.
So close. So it's kind of like a spectrum from least regular shape of the enhancements to most regular shape, meaning from like least circular to most circular. The most irregular is glioma or high-grade glioma or glioblastoma. The most regular is abscess, like the most circular, and then in the middle is metastasis. And like you said, a metastasis can have either the most or the least amount of edema. This has like not a lot of edema. Abscess also typically restricts on diffusion. So what would you do for this person?
I guess you would have to get a diagnosis to know like what it is, and so you could maybe do like Vicor, I guess. I think that if you went like subtemporal, it would be too high, and that you would have to go through the. Sorry, if you went subfrontal, it would be a little too high. You'd have to go through some normal brain to get it, and I don't know if it actually fall down enough for you to be able to resect. And then you can also go interhemispheric as well, versus like just Vicor, like through transcortical.
Would you do any other workup before operating?
Oh, sorry, yeah. So just like metastatic workup, CT abdomen pelvis.
Mm-hmm. And would you do any, based on the guy's history, are there any other like labs or things you would do?
Oh, since if he was immunosuppressed, then I guess you could have do like an LP and get CSF and make sure it's like not lymphoma, but the yield of CSF for finding lymphoma is really low.
That's true. And I think I said immunosuppressed, but this guy is immunocompetent. At least we think he is, or based on his labs, he is. Okay, so this guy underwent like you said, a transcortical approach using a Vicor tubular retractor to do a resection, also to obtain tissue. And this is what they found. Dr. Saad, do you want to share your screen?
Yes. Find where is. Oh, here it is. Okay. All right, so that's what we received. So at low magnification here, you can see that there is a cystic space and there is a tremendous amount of reactive inflammatory cells and fibrosis around it, which suggests most likely this is not a neoplastic process. So we're going to focus on this, on the cyst content here. Higher magnification. This is cysticercosis. So not all structures of the organism are present, but I'm going to highlight the ones that we can see. So this is the wall of the cyst that is supposed to attach to the host organism, which is the brain in this particular case. And what you see here, it's better to show high magnification. This is the convoluted canal, which is an important structure in the organism. So this is cysticercosis arising within the brain with adjacent dense fibrous tissue and severe reactive chronic inflammation and gliosis.
Okay. So this was Neurocysticercosis. It's the most common CNS parasitosis worldwide, and it's caused by the pork tapeworm Taenia solium. And interestingly, humans are the definitive host and pigs are only the intermediate hosts. And cysticercosis is caused when humans eat the Tania eggs. I'll talk about the life cycle on the next slide, but this is just a cool picture of the egg of the Tania solium, as well as this is some pathological findings in the cross section, looking at the cyst. So you get cysticercosis, or an animal gets cysticercosis when they eat the eggs. So and the eggs are usually in feces. So when a pig eats the cyst can invade the muscle or the brain or the eyes, typically the muscle, and then the human eats undercooked pork, which is, when you eat the pig, you're eating the muscle, and then in the digestive system in the stomach, then the tapeworm hatches out of the eggs, and then they create a lot more eggs, and then the human defecates, and then the eggs come out with the feces. So you actually can't get cysticercosis just from eating undercooked pork because you're not eating the eggs. The only way you can get the cysticercosis is if you don't wash your hands after you go to the bathroom, and then you ingest the eggs from you auto infect yourself from your feces, basically. When humans eat the eggs, then it typically goes to, again, muscle, brain, eyes, but most commonly the brain. And it's the most common cause of epilepsy worldwide. 70% of patients present with seizures. It's the most common presenting symptom. There's also something to be aware of called Brun Syndrome, which is basically if a cyst is intraventricular, it can obstruct the flow of CSF and then cause sort of a ball valve effect, and that can be very dangerous and cause rapid deterioration. There is both an ELISA and a PCR test with CSF, and the PCR test has a high sensitivity and specificity, so that can be used for diagnosis. If you're able to get a diagnosis with just like the CSF PCR test, you don't need a biopsy unless a lesion is causing, hydrocephalus, or if it's like massive and is causing a lot of midline shift or whatever. But typically, so this patient didn't have any fevers and didn't have a white count and didn't really have an infectious picture, but sometimes they do. And then in that case, I guess that could lead you towards the diagnosis without doing surgery. But a lot of people, especially non-endemic countries like the United States, it's not like the most obvious thing. So you can also, do a biopsy if there's no infectious picture. But the definitive treatment is medical, not surgical. Antihelminthic agents like praziquantel or albendazole. It's controversial whether or not to give patients steroids while you're treating with the antihelminthics because they can counteract the inflammatory response. So patients often get 2 weeks of dexamethasone. You may need to give the patient anti-epileptics if they're having seizures. And then again, if the patient requires CSF diversion, then they may need surgery. So this is the next patient. Sumed, are you on?
Yeah.
Awesome. Okay, so this is a 37-year-old woman, history of neurofibromatosis type 1. She presented with left anterior leg pain, 1 week of progressively enlarging painful lesion, let's say left lower leg numbness, worse in the left foot. And then over the last 2 weeks, the quality of the pain has changed from numbness to more throbbing pain and now involves the whole leg. So she underwent an MRI of the pelvis. Can you tell me what you see?
Yeah, so the first I see this hyperintense lesion in the left lower extremity, kind of the posterior aspect, and then a lot of kind of these smaller lesions throughout it looks like smaller lesions throughout the leg bilaterally. Looks like this could very well be like a neurofibroma, the larger lesion, and then the smaller ones very well could be as well.
Mm-hmm. Anything else on the differential?
It could be let's see. Yeah, it could be a schwannoma as well. It could be like intrinsic muscular tumor.
So I think you're on the right track with those peripheral nerve tumors, because if you look at this sagittal, you can see what's called like the tail sign, and that can be indicative of a intrinsic peripheral nerve sheath tumor. I mean, I think you were kind of saying those things based on the history, which is a good thing to do. But also, if you see that tail sign, then that leads you towards peripheral nerve sheath tumors. So you mentioned two benign ones. Are there any malignant ones out there?
I know there are.
Okay, we'll talk about it. It's very well named for what it is, but I agree that there's one dominant lesion, and then there's like kind of innumerable other lesions as well. So what do you want to, what would you do? Knowing that there is potentially this could be benign or malignant, you're not sure.
Definitely then you need tissue. So surgical resection of this lesion is causing symptoms for her.
So typically if you remove this, I mean, like there's like, nervous structures around, probably involving a nerve. Would you go straight to removing it? Would you do a biopsy to see what it is? Like how quickly would you be aggressive with this?
I'd start with a biopsy first. Something simple, and then progress surgery if necessary.
So I was kind of like tricking you a little bit. That can be done. It's a little controversial to just do like a small like needle biopsy or something, because if it is malignant, you can have a false negative, and also you can see the tracks, the biopsy tracks. So if you do a biopsy, you have to mark where the biopsy was, and you have to, when you resect the tumor definitively, you have to resect the tract as well, just in case there's been any seeding. I guess we'll talk a little bit more about what we'll do once we go over what this is.
Okay, so this patient had multiple lesions, as you guys mentioned. I'm going to start with the benign one. So this is a very common board question. We're looking at a neurofibroma at low magnification. There are two features of neurofibroma that are suggestive or strongly suggestive of neurofibromatosis. The first one is the plexiform growth pattern or nodular growth pattern, and it's obviously here very well illustrated. The second one is the myxoid degeneration of the tumor. So at low magnification, you can appreciate the presence of these foci of what appear to be hypocellular areas, which on higher magnification, they have this bluish hue, which is myxoid degeneration. And this is a neurofibroma. Also, if you look at the nuclei, they have this wavy nuclei. And in the world of pathology, once you use the term wavy nuclei, you're pretty much implying a neurofibroma. So this is a neurofibroma, plexiform and myxoid, strongly suggestive of neurofibromatosis, which we know that this patient has indeed neurofibromatosis. And here you can see this is neurofibromatosis, myxoid degeneration, and wavy nuclei. And then right next to it, you can appreciate that this is a different type of tumor. First of all, it's very cellular. And on higher magnification, it is atypical, meaning the nuclei are a little bit hyperchromatic, and there is necrosis. So every time we see necrosis, we become very worried about malignant transformation. And here we have, in addition to the remarkable degree of atypia, prominent nucleoli, we have numerous mitosis. So in this single high power field, we have 1, 2, 3, 4 mitosis, which is really, really high. So this is malignant peripheral nerve sheath tumor, or MPNST for short, arising adjacent to a plexiform neurofibroma. So how to confirm that? We do S100. One of the characteristic features of S100, although S100 is a neural marker, and one would expect that MPNST should be diffusely positive. Actually, it's not the case. S100 is supposed to be very focally positive in MPNST, and it correlates with the degree of malignancy. The more undifferentiated the tumor, the less S100 is expressed. But the confirmatory stain is a stain, we call it H3K27ME3, not to be confused with H3K27M, which is a marker for diffuse midline glioma. H3K27ME3 is a marker for MPNST, and it's pretty much almost pathognomonic and is characterized by loss of expression with nice internal control. So these are endothelial cells or inflammatory cells that have retained the staining because they're not part of the tumor, and the tumor cells are diffusely negative. So this is MPNST arising within and adjacent a pre-existing plexiform neurofibroma.
Okay, yeah, interesting case. This is the well-named malignant peripheral nerve sheath tumor. So you know it's if it's the peripheral nerve sheath tumor, you know it's malignant, you know what the name is. So these are very aggressive tumors, soft tissue sarcomas. They originate from the cells or differentiate from the cells of the peripheral nerve sheath. Very poor 5-year survival of 50%. And the two risk groups are of having one of these are patients with neurofibromatosis type 1 as well as previous radiation exposure. Actually, NF1 patients have a 10% lifetime risk of developing an MPNST. So just as a review, even though you guys just took the boards, NF1 is a mutation of the neurofibromin gene, which is on chromosome 17, also known as von Recklinghausen gene, which has 17 letters. It presents with multiple neurofibromas, cafe au lait spots, axillary freckling, leash nodules, and again, a 10% lifetime risk of MPNST. So just remember there's skin findings and eye findings. And because they have this risk of developing MPNST, they should be serially monitored just to make sure that they don't develop this. So MPNST is an asymptomatic. It can present either as an asymptomatic enlarging mass, or it can present with pain, neurological deficits, or paresthesias. Patients with NF1 are more likely to have large tumors, pain with presentation, or a sudden change in known neurofibromas. And again, routine total body imaging is recommended for NF1 patients in order to monitor and survey for malignant transformation. So in one large series, these patients tended to present late. They presented like 25.3 months after presentation, and they often presented with pain, 70%, a mass, 94%, or numbness, 36%. And the local recurrence rate after resection was 15.7%, so they need to be monitored for any evidence of recurrence. And about 1/3 of patients succumb to disease at an average of 78 months after surgery. This is another picture of the tail sign. This just can point you in the direction of a peripheral nerve sheath tumor. The grading system, at least at one point, incorporates the level of the tumor differentiation, the mitotic count, and the amount of tumor necrosis. And it's just important to keep in mind that a sarcoma is a malignant peripheral nerve sheath tumor only if it arises from a peripheral nerve or from a pre-existing nerve sheath tumor. Otherwise, it's just like a sarcoma. And then on pathology, there's a lot of different subtypes, but I think that the most common board like picture has these spindle-shaped cells in a whirling pattern. PET scan can be very helpful. to help distinguish MP-NST from benign tumors, as well as for staging. Sometimes both benign and MP-NST tumors can be painful. So the brighter it is on PET scan, in fact, there's a SVU cutoff that can be indicative of an MP-NST. And then for treatments, it's controversial to do a needle biopsy. A lot of times there can be false negatives, and you can see the tract. If either you do a needle biopsy or if somebody else does one and refers them to you, you need to resect the tract as well. Because they're so aggressive, you want to perform a wide local excision, which consists of resecting both the tumor mass and then normal adjacent tissue in order to ensure negative margins. You want to try to attempt to salvage the limb, although it may require amputation proximal to the tumor. And you just have to counsel the patient before surgery that they may lose function after the surgery. And then ancillary treatment is it's sort of developing, although there has been some successful treatment with ifosfamide, doxorubicin, and cisplatin in terms of chemotherapy, as well as radiation therapy in cases where there was wide local resection. Okay, and then this is the last patient.
And
Again,
great job. I just wanted to make a couple of comments. I mean, it's been a long time since I've read that paper, but I think the 25.3 months presentation is for, benign tumors. I mean, usually malignant tumors present pretty rapidly within weeks or months, and that's a hallmark of its malignancy. So I think some of those numbers relate to benign tumors, and certainly the paper focus was all tumors with a particular focus on benign tumors. The thing with the biopsy, I mean, if you suspect it's malignant, then doing a biopsy is the right thing to do. And doing it ultrasound guided percutaneous is the right thing to do, because you want to know preoperatively what your surgical plan will be. If it turns out to be malignant, then you're going to do a wide local excision. And if it's benign, you're going to do, a benign tumor removal. And you're going to have a good idea if it's malignant or not based on the MR characteristics, the PET CT, and the results of the needle biopsy. It's true that there are some false negatives, but that's not a reason not to do a biopsy. So those were the only comments I had. I just didn't know what was actually done in this particular case. Can you fill us in, either Dr. Eichberg or Cote?
Yeah, definitely. So the pictures that were shown were not actually the tumor that was resected. That tumor within the gluteus was actually low grade based on the PET scan that was done post-operative of a distal left lateral lesion that was associated to the sural nerve. And so when I went in, I took the sural nerve tumor out, which was relatively large, probably the size of a mandarin. And I did send intraoperative path, and it did show concerning findings. So I did take a little bit more out and had relatively negative margins, closed up. And then after got the PET scan, and there was a secondary lesion within the pelvis associated to the femoral nerve within the psoas muscle that required a large excision as well. And then she ended up getting radiation and chemotherapy. So a very complicated case.
Okay, well, thanks, Dr. Levy, for clarifying those points, and Dr. Cote for going through that. Okay, so this is the last case. Silva on? He was on for a second. Okay, awesome. Okay, so this is a 30-year-old healthy male, no past medical history. He had an MRI of his C-spine because he was having some shoulder pain radiating into his neck, and he's neurologically intact. He had this finding on his MRI, or he then got an MRI brain, obviously. Do you see anything? It's subtle, but do you see anything abnormal?
It looks like maybe in the tectum, there's a like T2 hyper intensity and a T1 hypo intense like lesion there.
Yep, exactly. In the tectum. Any thoughts about what it could be?
On the differential B, so it's not enhancing. I would think maybe a low-grade glioma versus doesn't seem to quite be arising from the pineal gland, but potentially a primary pineal tumor. How old's the patient again? Sorry.
30.
Okay, so you could also think of a germ cell tumor in this area, but I would think low-grade glioma is a higher on my differential.
Okay, perfect. What would you do for him?
Do we have serial imaging, or this is the only one?
This is the only one.
Yeah, I mean, I guess, ideally it would be getting tissue for pathology, but obviously a high risk region to get tissue. So you could also consider just getting serial imaging in a few months and seeing if it changes at all.
Yeah, I think that it's reasonable to get some serial imaging. It's non-enhancing, so it's not immediately concerning for anything high grade. So it could also potentially be nothing. So like you may want to give them at least one chance to have it just be stable, to see if there's any growth. And also tectal gliomas often have very benign, at least low grade ones can have like very indolent courses, benign courses. So you don't want to just like rush to biopsy this. There's not really any concerning findings. And then are there any other, so the guy is neurologically intact, but are there any like clinical syndromes that you should watch out for? I'm thinking of two different ones that he could develop potentially.
You could get potentially a Paranon syndrome from the Mass Effect in this region, although it doesn't look like it's too large quite yet.
And what's Paranon syndrome?
You would get difficulty with upgaze, and you get loss of accommodation.
And there's one more.
Not remembering.
Convergence nystagmus. So there's upgaze palsy because the upward gaze center is in the superior colliculus, which is part of the tectum. So that's why tectal lesions can cause that finding. So you have like the sunset eyes that can't look up. Pseudo Argyll-Robinson pupils. Argyll-Robinson pupils are like the syphilis finding, but pseudo Argyll-Robinson pupils are paresis of accommodation. So they're mid-dilated and they have near light dissociation, and then convergence retraction nystagmus. Okay, so that's one, and then another one that's like more like less esoteric, I guess. Like what dangerous thing could happen if this were to grow?
Yeah, he could develop a sepsis. It doesn't look like he has quite yet.
Yeah, exactly. And I guess like historically, a lot of people with like aqueductal stenosis, like kind of in the pre-MRI era, like it's thought to be like related to having tectal gliomas. So, so we talked about these things. So then you got MRI in 6 months, and then now this is what he has. So what happened, or what are you seeing now?
So it looks like 1, it's grown, and 2, it's now enhancing.
Yep, exactly. And is it localized only in the tectum now?
No, it's kind of spreading to the, I guess it's like posterior thalamus there. So yeah, it's definitely spread.
Exactly. Okay, so what would you do?
Now he definitely needs tissue for diagnosis.
Yep. And how would you get that tissue? Biopsy, open surgery?
I would do an open biopsy. Can probably get to it from a supracerebellar frontotemporal approach.
Okay, perfect. Why why is needle biopsy a good idea? And if not, why in this area?
I mean, it's very high value real estate and lots of very delicate structures nearby. It's gonna be lots of veins in that area that you would want to avoid, and I think it'd be hard to do a stereotactic needle biopsy.
Yeah, so the basal vein, Rosenthal, internal cerebrals, and Galen are going to be right there. So incredibly high risk. So if you want to biopsy this area, you typically want to do it open, and supracerebellar infratemporal is a great approach for that. And that is what was done. I'm just showing it involving more of the right thalamus. Talked about that. Okay, and then the pathology.
All right. Okay, so this is an excellent example of illustrating the recent advances in neuropathology. So what looks by histology and by imaging low grade doesn't have to be really low grade at the molecular level. So this is a low magnification. This is an excellent biopsy, actually, given the location of the tumor. And you can appreciate that this tissue is hypercellular. And on higher magnification, not every single cell here is neoplastic. The ones that are neoplastic are the ones that are elongated. Remember that astrocytes are generally oval. And when they become malignant, they acquire an elongated, almost spindle cell appearance. And this is very important for them because once they acquire a spindle or elongated appearance, they can migrate further. They can navigate between the axons and the other tissue. So this is an astrocytoma. There are no high-grade features at all, no tumor necrosis, no vascular proliferation, and not a single mitosis. And why it's astrocytoma? Because it expresses GFAP diffusely. And this is Ki67, which is also supportive of the histologic impression that this is indeed a low-grade astrocytoma. So 7 years ago, we would have called this diffuse astrocytoma WHA grade 2. But in the last seven years, there was significant advances at the molecular level, and this is H3K27M, not to be confused with H3K27ME3, which we use for NPNST. This is H3K27M, and when it is expressed, it indicates that this tumor harbors mutation of the H3K27M gene, and therefore it behaves like a glioblastoma. So we render nowadays, I'm sure you've seen some of the reports, it says integrated diagnosis, meaning by histology, this is a diffuse astrocytoma, but at the molecular level, this is basically glioblastoma. It's a WHO grade 4, and it will behave like glioblastoma, and that's why we did NGMT hypermethylation testing, and it is negative. So this is diffuse astrocytoma. It's a diffuse midline glioma, basically, which by histology is diffuse astrocytoma, but at the molecular level is a glioblastoma grade 4.
It's unfortunately very unfortunate for this patient. Okay, so we have a treat. So we have a expert in the field, Victor Liu, who did his PhD on this tumor. So he is going to be telling us a little bit about the scientific breakthroughs that are occurring in this field.
Hi, and thanks everyone for the chance to talk. When I was at the Daniels lab, we specifically looked at H3K27M, so it's a great chance for me to quickly run over perhaps what's more clinically relevant for us moving forward with this mutation. This here is an imaging. You can see it's a midline structure. Typically, these mutations have been associated with DIPG, which is where this image comes from. Since 2016, this mutation has been its own identity, being the mutation of the self-diffuse midline glioma. Typically before that, we typically saw this in children, and it was termed diffuse intrinsic pontine glioma, normally occurring in the pons. But since then, we've realized along the midline of the whole neuraxis, this mutation can occur. And so given it this diagnosis, just quickly, the biology of this is perhaps a bit beyond the scope of this talk, but these 5 minutes, but typically we have histones in our DNA, and on the H3, the H3 histone, the wild type, we have a lysine at site 27. This can be methylated by the PRC2 complex. Long story short, when you have this trimethylation at H3K27, it leads to post-translational modifications that are involved in various cellular functions. It's believed once this is disrupted, it then can increase the tumorigenic burden of particular tumors. So when we have this H3K27M mutant at the bottom, you can see that the PRC2 complex is now sequestered. It cannot go on to trimethylate further histone 3s, and therefore ruining the epigenetic landscape of what would be a normal cell. It's this belief here actually that leads to thinking part of the reason of how these tumors progress. As I earlier mentioned, these mutations were first seen in children within the pons, and we've been able to show multiple times that this mutation itself is bad in kids. It's bad in terms of overall survival, and it can also be very metastatic as well, as you can see in the case report to the right, with diffuse spread. These children typically live up to a year, and the only real standard of treatment we have right now is radiation. Multiple chemotherapy drugs are being trialed, but nothing's being shown to be as more effective than just radiation alone currently, although many trials are underway. But again, this is in children, typically in the pons. What's interesting is now, as we learn more and more about this mutation and we look for it more and more in adults, I'm of the belief that this may actually be different. You can see here in table 1, we looked at H3K27M mutations in adult cerebellar tumors. And in fact, if you look over to the right, the median overall survival was actually greater in cases that had the mutation versus the wild type, which is counterintuitive to what we're preaching about in children. There's also been some research in the spinal cord tumors as well. And we wrote this in response, saying that it is strange because this study here demonstrated that in spinal cord tumors of adults, those with the H3K27M mutation actually lived longer than those with the wild type. So it's very interesting to say, within adults at least, the evidence of it being such a poor prognosis versus wild type is not as robust as in children. There are many ways to target these midline tumors. This is some of the work we did before using convection-enhanced delivery into these mouse models. Unfortunately, we're not always able to resect these midline tumors, especially when they're in the brainstem. And there's multiple groups here in the US working towards trying to have this permanent implanted device that can develop various therapies. I think we're at the stage now where we can develop and deliver therapies. The issue now we face in this arm of treatment is what therapy is effective. Nothing has been technically shown to be as effective just yet. On the right, there's also an arm for reirradiation. We've been able to show that these DIPGs, or these midline gliomas that get reirradiated in the brainstem, actually do better. And there are actually a couple of clinical trials now trying to see whether or not we can establish a particular standard of care reirradiating after their initial radiation, perhaps a progression, perhaps at a more established timeline. There are multiple clinical trials currently going on. As you can see, as the years get older, we have more and more studies popping up, and a lot of them are happening here in the US, not much elsewhere. Part of this is because DIPG and H3K27M mutations are so rare that in order to have enough to really develop a clinical trial, you have to be in places that have the number and volume. And I suspect here in the US, we have that, as well as the resources and finances to conduct these trials. Technically, where are we heading towards in the future for H3K27M? I think on one side, they're developing different liquid biopsy techniques, CSF and the blood and the plasma, to look for nucleosomes within there to perhaps detect these H3K27M mutations, loss of trimethylation, and various other post-translational modifications. It circumvents the issue of biopsying the pons, at least in the DIPG setting, and also it provides us a way to perhaps monitor response to clinical trials and clinical therapies if we can get it working. You can see here in the third image in this bar that the trimethylation was reduced in our tumor sample, although it was an N equals 3. On the other hand, there are multiple chemotherapy and drug targets that people are trialing right now in clinical trials to see whether or not we can alter the disruption that the loss of trimethylation causes within the epigenetic landscape of this disease. Finally, it's a really interesting point to state that not all midline gliomas are technically H3K27M. It's an interesting point. On the left, we had a case that was a midline glioma, but it was a wild type. The prognostic significance of that is not clear. The patient had an overall survival of 15 months, which is around the same time expectancy of those, maybe a little bit longer with a mutant variant. And on the right, we also had this H3K27R mutant, which is not technically H3K27M. That patient was doing well 12 months since diagnosis. And so not all that glitters is gold and not all that is midline is technically H3K27M. And I just wanted to end on that note.
Yeah, it's not recommended to use the term diffuse midline glioma for those who do not harbor H3K27M. I think it's recommended to stick with the IPG for the time being to avoid any confusion.
Okay, well, great presentation, Victor. Dr. Saad, thanks again for your time. We know you're very busy. We always learn a lot from you.
Okay, thank you, guys.
Thanks, guys. So I'm going to give my grand rounds talk. I'll proceed. Everyone can hear me? We're good? Okay. So this will be my fourth talk about nerve repair. Some of it we'll go over, will be basic, and then we'll get into some of the new topics that I was finding while reviewing the literature, and some stuff from sort of our lab experience here in Miami, as well as clinical research experience. So here's our sections and outline of the talk as I just went over. Let's just talk quickly about the nerve anatomy. Basically, do we have all of our juniors on here? Okay, seems pretty good. Okay, so anyway, axons extend from the nerve cell bodies and get enveloped by a series of Schwann cells. And in response to contact with the axon, the Schwann cell constructs a cylindrical basal lamina, which becomes super important for many reasons. And that basal lamina becomes the endoneurial layer. And I'll go over that again. It's constructed of a type 4 collagen, which is different from type 1 collagen, which is more fibrillar. Type 4 collagen forms in kind of a sheet or plane. So you'll see a picture of it in a sec. Here it is. Basically, this is that basal lamina that's constructed by the Schwann cells that occurs in response to the axon bridging out from the cell body. It's cylindrical, is the endoneurial layer, and it provides crucial function and support for the axons in normal health and injury. And I'll go over again its importance in regeneration, but it's really important to keep this kind of image in your mind when you think about axon, or when you think about nerves on a microscopic layer. This is kind of cool. Basically, the caliber of the axon diameter determines the fate of the Schwann cell surrounding it. So it's very much a conversation between the two cells. And the A and B fibers have a one-to-one relationship with Schwann cells, whereas the C fibers are bundled in these Remac bundles. You can see here, the C fibers are the non-myelinated fibers, and a single axon can sheath several C fibers, versus the A fibers are the largest and fastest, C being the smallest. Here's a picture of the myelination that occurring within that basal lamina. Larger axons have longer internodal lengths and increased myelin cross-sectional area. So let's go from cellular anatomy to structural anatomy. And as we get more and more into the clinical realm, basically, there's the outer layer, which is epineurium. There's a perineurium and endoneurium. Epineurium is the outer layer. Again, it's constructed of type 1 collagen, and it can accommodate significant stretch. The perineurial layer is not tolerant to stretch. This is the sort of fascicular anatomy. It does have gap junctions, and it creates a diffusion barrier. Then there's the endoneurial layer. This is the basal lamina. This is that Schwann cell tube where the axons live. This is a microscopic layer. Axons do have sort of a there is a microscopic anatomy within the nerve itself. So there's kind of a layout of the axons to a particular muscle group, but it's not consistent sort of along the length of the nerve. So you couldn't pick up a nerve proximally and know exactly where the axons are, because there's a lot of intraneural plexus that goes on and shift of the axon fibers. You can see as you move distally in this monkey median nerve that the axons that go to the thumb move around. So let's talk about injury quickly. Basically, when the axon's injured distally, the cell undergoes a neuronal reaction, and that occurs through 3 mechanisms. And this becomes interesting when we talk about repair strategies, one in particular that I'll go over. But there's a natural electrical activity, then there's a deprivation of signals, and then there is retrograde transport of new signaling molecules to tell the cell body, hey, axon's injured, we need to start the repair process. So the first one I mentioned was the electrical activity. There's a large depolarizing voltage goes back to the cell body. It results in calcium influx, CAMP mediated pathways. And then the loss of negative cues we mentioned, retrograde transfer to new signaling molecules we mentioned. This is a really interesting review that goes over sort of the detailed process that occurs at the tip of the axons as they grow. And basically, they sort of liken it to a car traveling down a road where there's the road signs, and then there's other cues along the way. And all this happens via a actin treadmill and then microtubules coming down this actin chain. I won't get super into this, but it's an interesting article that you can check out. And so as we went over that basal lamina, the disruption of the basal lamina really will determine the severity of the injury and how well the body can repair it. Because if the basal lamina is intact, like a crush injury, well, then the axons proceed back down their specific paths with high degree of precision. And you can see that here in this model where they show before and after exact same axonal patterns. Versus if you have a transection, the basal lamina are disrupted, you may get some appropriate, but you also get inappropriate targets. There is some degree of specificity in reinnervation, and it has to do with Schwann cells expressing certain microRNAs, and some of the Schwann cells that previously myelinated motor axons will express certain microRNAs that won't be expressed by the sensory myelinating Schwann cells. Here you can see what happens at that site of nerve repair. This is an area that was transected. Axons can go pretty much anywhere. They can actually cross back into the parent and proximal nerve stump, and that can lead to neuroma formation. So just quickly, what happens to the axons and fibers distal to the injury? Well, basically the Schwann cells undergo a process where they re-enter the cell cycle, they participate in myelin clearing, and they proliferate. So they actually have a proliferative response after injury. And this is all part of the process of Wallerian degeneration described a long time ago. Of note, after you cut a nerve, there's a latent period where the nerve will still stimulate, will still have electrical conduction, and that can last up to potentially up to 78 hours, but definitely 48 hours. What is the speed of regeneration? Well, we usually say a millimeter a day, just to be conservative. The estimated speed is reported and measured at 3 to 4 millimeters a day, or 2.5 millimeters a day after transection. But one big factor here is the ability of the axons to actually cross that suture line. So when you're repairing two nerves together, you're going to have a suture line for them to cross. And there is about, to simplify, a 1-month latency period that axons are actually able to cross that suture line. And it has to do with the disruption of those endoneurial tubes, the basal lamina. And I mentioned that selection that occurs via Schwann cells expressing variable microRNAs. But even with meticulous repair of both proximal and distal stumps, those axons will face a hostile environment in the area between the stumps with blood and debris. And the axons are very tentative as they grow. They need positive reinforcement. They need positive and negative cues to continue their growth. Otherwise, they'll sort of stop and turn into a neuroma formation. So that's interesting. As axons advance distally, they adhere directly to the basal lamina, which I noted. Distal to the injury, that Wallerian degeneration process, the Schwann cells are proliferating. They live in the endoneurial tubes, and that's what's referred to as the bands of Bungner, just so you know. Okay, so let's just quickly talk about the clinical factors in nerve injury. Obviously, age is a big factor. Patients who are younger do better. How proximal you are with your lesion tends to affect the motor more than the sensory recovery in these studies in the upper extremity. The timing of repair, how long you wait before repairing it, also affects how well the patients recover. Although this is a little bit complicated in nerves, injuries in continuity, you know, the repair itself has an effect on how well the patient does, and the operating microscope certainly helps. And here's when these microscopes were introduced. Faulty localization, which we mentioned. An interesting topic is how complex is the nerve that you're actually repairing? Well, the spinal accessory nerve can be cut and repaired, and patients tend to do pretty well because it's a very specific function. The nerve is a solely motor nerve and innervating one or two muscles, versus the facial nerve has innervation of 17 muscles, and even in the best hands with graft repair, end-to-end repair, you have these results of House-Bachmann 3 recovery with a high degree of synkinesis in both patients. So that's an example of that faulty localization occurring at the suture line, where axons may go into different places than they were before. You can see this patient has significant synkinesis on the left side. So, okay, so let's just quickly talk about the types of injury. And really all you need to concern yourself with is neurotomesis, neuropraxia, axonotmesis, not so important. And I'm speaking to the junior residents here. We won't go into the sort of grades, the Sunderland classification, but basically the cutoff between axono and neurotomesis is that disruption in the basal lamina. So to go over the rules for nerve repair, because this kind of becomes a confusing subject in our early training days, but a clean laceration should be repaired in 2 to 3 days. And this all follows this rule of 3. So a clean laceration repair in 2 to 3 days, a blunt laceration repair in 2 to 3 weeks, and injury in continuity, we need to wait a couple months because you have to see if the patient's going to recover at all on their own. One we see a lot is a gunshot wound. And if you're called about a gunshot wound, it's a little tricky because you often can't get an MRI. So get a CT, see if we can get potentially an ultrasound in the area. But you're trying to determine, is the nerve completely disrupted? Probably not. Probably it's just an injury created by how forceful the bullet travels through the tissue. In either case, it's unlikely to be explored early. Okay, so let's go into the repair process. How is it actually done? How do you do these repairs? And I know, you know, as a junior resident, I'm sure you've seen people repairing nerves, but what is actually going on? And that process is called neurorrhaphy, and it's basically proceeded in the following way. And you identify the nerve proximally and distally, as you would in a lot of cases where you're dealing with scar. You identify normal anatomy above, below, and you free up both the proximal and distal nerve segments, making sure during the repair there's no tension on either of the nerve ends. Typically we'll use a suture, but there are reports of use of just fibrin glue. We often use a suture with fibrin glue. There's other adhesives and tubularization techniques that are used. There's 3 grafting techniques, which we'll talk about, but we're often using the epineurial sutures. Here you go. So there's the epineurial sutures, there's the perineurial or fascicular sutures, and then there's the interfascicular repair, which is kind of like really only relevant for very large nerves with grafting. So the epineurial neurorrhaphy is suturing onto the epineurium, as you would think, and you use 8 or 9-0 sutures. The important thing is to make sure that you've identified normal fascicles, and this can be kind of tricky. In the orthopedic literature, they talk about using frozen histology to send the sections for frozen to make sure that you have normal fascicular anatomy, you're not seeing scar. Typically try to place the deep suture first so that, you know, you're not placing it at the end where you have to roll the nerve around and get it. This may be sort of similar to bypass techniques, but you're not really on the clock in nerve repair, which is nice. So it's a good place to get started for your micro suturing, and we'll have that. If anybody's interested in coming to the lab, that's definitely an option. So basically, also you want to have kind of a clean look at the end without excessive suturing, because that can lead to scarring. So that's the epidural repair. I went through this maxillofacial literature. They talk about peeling off the connective tissue on top of the epineurium, which can, in their hands, apparently lead to fibroblast ingrowth. That's the only time I saw that mentioned. A little bit interesting. They do recommend using the microscope. We always use the microscope, and if you're using epidural repair, 8.0, 9.0 is fine, but you can use 10.0. For fascicular repair or perineural repair, you really have to use 10.0 sutures. You have to use the microscope, and you don't do the epidural closure on top of it. This is only relevant if you're reconnecting a large transected nerve in a clean transection, probably. So we don't often see this, but when we will do is, let's say you're repairing the sciatic nerve, you probably will use this interfascicular neuropathy where you're taking sural cable grafts and actually suturing them into large fascicles of the sciatic nerve. Again, you'll need 10.0 sutures. So those are the types of nerve repair. These are comments from Sunderland, when to use the fascicular repair. And he basically says if the fasciculars are large enough, if the pattern would predispose to waste if you just did an epidural repair, and there's a constant position at the nerve ends. I don't know how you would know this last part, but these were his comments. Are there any evidence that pushes us towards one type of repair over another? Here's an article from 1977 that looked at comparing fascicular, interfascicular, and epidural sutures. They didn't find any difference in the recovery in these animals. This was a dog model, anterior tibial nerve laceration. And they used 10.0 sutures at high magnification. So theoretically, you know, that's in the best case situation, although that is pretty old literature. Anything newer. Here's a nice review by Raj Mehta and company. Again, they actually found no clear benefit of one repair technique over another. So they just commented that surgeons should use the technique best suited to the anatomy. If very large fascicular groups present, well, then you can suture the grafts into the fascicles, as we talked about. But really no evidence I could find that supports one type of repair over another. Here's an example of a sciatic repair that we've done, basically, you know, and it's a kind of a combination of suturing the ends into the epineurium and perineurium. It's really not always that clear in the repair, but anyway, so those are the different repair techniques. And basically what we've been talking about so far is autograft. And autograft is great because it brings in patients on Schwann cells and you have that basal lamina support. The disadvantage is that you have to, as you've seen, you have to make big incisions on the leg. There's increased time and there's significant size mismatch, as you can see here. What can we do to improve this? Here we just talk about how quickly the donor nerve runs out in a sciatic nerve gap. Here's another example of a sciatic nerve repair, and you can see how long these grafts have to be. This case obviously is a very severe injury, though. What are the ways we can supplement repair? Well, there's these axon guidance channels. These are hollow tubes that were first introduced a really long time ago. Hollow tubes are difficult for the patient or animals to recover because the Schwann cell has to migrate into the tube, which Schwann cells have a limited migratory capacity without any kind of biochemical like promotion. And that has to occur before myelination. So really, these are probably not well suited in repair unless you're talking about a really small gap. And this is just a median monkey nerve model where they compared autograph versus nerve guides, and showed as you increase the distance, the nerve guide performs worse. So some authors in this case have suggested that really shouldn't use conduits unless the gap is less than 3 centimeters. Okay, what about new improved conduits? Well, the FDA has at least 11, probably more. Couldn't find any updated literature on that, but let's say a dozen at least conduits that are FDA approved for nerve repair. What makes these different than just a hollow tube? Well, they have some structural support. And this is a paper from 2012 that looked at this Integra made conduit that tries to recapitulate the basal lamina with longitudinally oriented channels. And they showed pretty good results with that. Still not as good as autograft repair, which is kind of an artificial gold standard in animals because you don't have a autograft in humans that's as large as the actually transected nerve. So what about using allograft? Can you take a piece of donor nerve that's the exact same size? Well, the patients need immune suppression, so we don't really use that. What about acellular autograft? That is a product that's available off the shelf. It, again, can be sized almost perfectly. The problem is that there are no cells in these grafts. So again, it's kind of like asking a little too much of the axons, because like we talked about, the axons really need a positive support from the Schwann cell specifically. So in a long acellular graft, they probably won't grow all the way through it. These can be used in short digital grafts. So these small diameter digital nerves are kind of just, you can put them in there to fill a little gap, but that's kind of the only situation that they really should be used in. So we talk about the importance of Schwann cells. Let's look at some ways that they can be incorporated. So these acellular guidance channels or conduits are nice because you could potentially use them to introduce cells into the repair site. And groups have looked at bone marrow stromal cells and other types of stem cells. And people have shown in animals that these cells do help, specifically in the rat sciatic nerve injury model. No reports in humans that I could find of these being used yet. But they have been used in animals, and that's talking about bone marrow stromal cells and other types of stem cells. Schwann cells, on the other hand, we are using here in humans, and they are pretty natural choice for cell supplementation if you're going to pick something. And so here's our publication from this year, basically looking at the addition of Schwann cells into that second generation conduit that I showed you, where it has the basal lamina recapitulated. And we found good results with this. We found that you can see here the number of myelinated axons in this D column was almost the same in the reversed autograft, which is like a positive control. And then the conduit alone performed poorly in basically all the ways we looked at it, including EMG. And we were lucky to have a person who's not listed on here, but Natalia from Spain, actually, she helped conduct electrophysiology on all these animals. I'd bring them down to the 3rd floor and she would do the electrophys. It was really, really helpful. So I'm hoping that moving forward, we can find somebody to help us with that. Anyway, so we found that we could add Schwann cells to the conduits and they worked very well. What about just adding Schwann cells alone in nerve repair? And this is what's ongoing now in our clinical trial. This is basically the procedure laid out. This is what it looks like intraoperatively. And we inject the Schwann cells into the nerve repair site, as you can see here, with autograft also used. We wrap it. Here's our criteria. Any basically nerve injury greater than 5 centimeters, where that's where these can be potentially utilized. And I think it's a really nice idea. And I think if we can kind of optimize how these cells could be delivered, which I'm hoping to work on in the next year or two, then we can probably make a meaningful impact. Let's talk about some other interesting subjects in peripheral nerve repair. And one in particular is electrical stimulation. This has been, I'm blanking on, Tessa Gordon is the plastic surgeon, Canadian plastic surgeon, who's published a lot on this. And I'll show you a few clinical trials where electrical stimulation, ES, really improves nerve repair in their hands. it's basically, here's the mechanism: retrograde conduction of action potentials via electrical stimulation increases intraneuronal cyclic AMP, induces more rapid and sustained upregulation of regeneration-associated genes. We talked about that effect when the nerve is cut. That's the first thing that happens, is that the cell body receives an electrical signal. Well, this may be amplifying and utilizing that pathway. These experiments actually date back to the 1950s. Nerve stimulation is not a new idea, but these may be new applications. You know, how much stimulation should we use? How long? These are animal experiments that have been worked out. In 2000, authors showed that that electrical stimulation via wire wrapped around the proximal nerve stump significantly increased motor axon recovery, regardless of the duration of stimulation, whether that was 1 hour or 2 weeks. This is a rat femoral nerve model. So they basically injure the nerve and then stimulate. They keep a catheter, they keep an electrode around the proximal stump, and they stimulate the animal either for an hour or 2 weeks straight. Seems to be sort of an on-off switch, because the 1 hour worked just as well as a 2 week stimulation. So that this, among other studies, led to clinical trials ongoing. And this was a review of all the clinical studies by Tessa Gordon and others. And I'll show you that the results are actually promising. So here's a study published in Experimental Neurology, and Dr. Levy, I included the impact factor just so we can all see how you know, powerful these publications are. But these all have been cited quite a few times. This was in 2010. This is in carpal tunnel patients, and they received 1 hour of electrical stimulation after the repair, and they had 12-month follow-up. They had enhanced motor recovery at 6 to 8 months and at 12-month post-op follow-up. There was no improvement in their subjective feeling, you know, in terms of stimulation versus control, but their motor function did seem to be improved. And all these studies that I'll show you were blinded to the people that were assessing their outcomes and to the patients as well, in some cases, unless the patient was awake. So this one used electrical stimulation post-op in the recovery room. Here's one where they also used electrical stimulation post-op, published in the Annals of Neurology. 2015, digital nerve transection with suture repair. Randomized and double-blinded, received 1 hour of sham stimulation in some patients, and the 20 hertz 0 or 0.1, I can't remember the actual how much electricity is given. I have it listed somewhere around here. But anyway, 18 patients in each group, followed for 6 months. The electrical stimulation group had significantly better sensory metrics in these cases. The questionnaire data trended better, but was not significantly better in the electrical stimulation group. Here's another study. This journal was a little lower impact. I ran this by one of my ENT colleagues. I'm not really sure how this makes sense, but it's interesting. So these patients underwent a level 2B neck dissection, all of them. In half of the cases, they did electrical stimulation intraoperatively, and in half of the cases, they did not. And while they were doing their dissection, they had a stimulator on the spinal accessory nerve, and they stimulated it for 60 minutes. After 1 year, combined subjective and objective shoulder scores for the electrical stimulation group were significantly better than the control group. And the electrical stimulation group experienced only 25% of the functional loss seen in the control. So this is the new concept to me here, is that during neck dissection, that it's expected that the patient will have some degree of shoulder dysfunction post-operatively. So electrical stimulation seems to mitigate that. I think I listed out here what the 2B was, and you can kind of see it's right next to the spinal accessory nerve down here. I don't know if you can see my cursor, but there's the 2B dissection. These are all the levels of neck dissection. Here's one that was just published in our own literature for severe cubital tunnel syndrome. This is a double-blind randomized trial where electrical stimulation was used again for 1 hour post-operatively with 3-year follow-up, and the post-surgical electrical stimulation enhanced muscle reinnervation and functional recovery better than surgery alone. So it appears that there may be a role for electrical stimulation, and can we use it? Well, there have not been any studies looking at it in a nerve injury with a gap, which is something that we could potentially look at. Additionally, there may have a role in preconditioning for nerve tumor cases, it may be helpful to intraoperatively electrically stimulate proximal to the lesion for an hour. I don't know if this would get kind of in the way with the leg jumping or the arm jumping, but this may be helpful. In my mind, it seems to be an on-off switch, ramping up the cyclic AMP mediated pathways of regeneration in the nerve cell body. So I found that to be interesting. So let's talk about now last.
Hey, Shelby, good stuff. You know, so when we were talking about this before, I thought you were referring to electrical stimulation of muscle post-injury, which is there's a lot of data on that, and patients often ask for it. And intrinsically, it kind of makes sense that if you continue to stimulate the muscle, that you won't lose muscle receptors during that deafferentation period. But that's where there's like zero data to suggest that it's helpful, and that's why we don't supply stimulators to patients with peripheral nerve injury. But this is something totally different. What you're talking about is electrical stimulation of the nerve, and I definitely believable. Lots of basic science data and some clinical data. I think the clinical application is the tough thing, is like to keep a nerve stimulator on a nerve post-op for many months, like what Tessa Gordon was doing in her animals, is tough. But if it could only be an hour during surgery, that's definitely 100% doable, and worth looking into. With regards to tumors and electrical stimulation, with our bone growth stimulators, one of the contraindication is patients who have previous cancer. So I could see that being an issue in trying to get an IRB or something like that for stimulation in tumor cases. But thank you.
No, thanks for the comment. I think it's a sort of, my understanding is that it seems to be kind of an on-off thing where like 2 weeks doesn't help any more than 1 hour, and 20 minutes might not be enough based on animal data. So maybe, yeah, or maybe even for nerve repairs of with a gap, you could stimulate proximally while you're doing the repair. It wouldn't cause any muscle jumping probably. Yeah, so that's interesting. So my last thing is basically when repair is not an option. And we've talked about nerve transfers in the past. I brought it up. I've talked about it in grant rounds. Obviously, Dr. Levy, Dr. Cote are doing a bunch. We've done a lot together. This is sort of the typical combination of nerve repair because well, first of all, nerve repairs are basically nerve transfers I'm talking about, nerve transfers, sorry. Nerve transfers are only done really in the upper extremity. I think there are some in the lower extremity, but really we're only doing upper extremity nerve transfers. And this is the typical combination for an upper trunk injury to the brachial plexus, where you do in any combination, but typically we'll actually do this last one first, the Oberlin first. So ulnar plus or minus median to the muscocutaneous, that's called the Oberlin transfer. And then we've been doing from a posterior approach. I'll have to review the data on this, but we'll do the spinal accessory to suprascapular and the radial to axillary transfers. So we're trying to reestablish the sort of bicep elbow flexion and the shoulder abduction deltoid. We really should, I was thinking we should look at our own series and see how these patients are doing. I have the privilege to work in the OR, but I haven't been seeing them in the clinic. So I hope they're doing well. But that's something we should look at. So let's say nerve transfer is not an option either. The patient has significant pain related to neuroma formation. I haven't really talked about this much. It's not a thing that we see a lot of. It's mostly plastics, but it's really fascinating to think about because it has certain implications for nerve recovery. But patients who undergo amputation very often have stump neuromas. And this whole concept of TMR that I'll talk about was introduced to me at the Joint Spine section in Las Vegas with the spine group, with the nerve group there, talking about this. And anyway, there's a high incidence of painful neuromas after amputation. And there are over 150 proposed therapies. This is listed in so many articles. There's a lot of proposed therapies to treat in neuromas. And here are a few examples of things people have done. suturing two nerves to themselves is one option, and putting sort of a cap or something on the nerve end. And I know Action sells like a nerve cap you can use. Suturing the nerve into bone actually is something that people do. I don't understand the rationale of that. And actually, patients can develop a compression syndrome at the site where it's sutured into the bone. But anyway, there's some literature on all these types of repairs. But a newer one, newish, described in the early 2000s actually for allowing amputees to control smart prosthetics. And I wish Ian was here because I've talked to him a little bit about this, but it's interesting. They sort of have this very choreographed, planned way that they would reattach nerves, and then they'd use, I believe, EMGs to control the prosthetic devices. And they discovered that these patients had very little neuroma pain. So in a publication from 2014, they showed 15 of the patients who had neuroma pain before TMR, or targeted muscle reinnervation. That's what this is for the control of the smart prosthetics. So 15 of these patients they looked at who had horrible stump neuroma pains, 14 of them had complete resolution of their pain, and the other one was able to significantly cut down on analgesics. And the author suggests that this reestablishes the continuity of the peripheral nervous system, allowing those nerves to have sort of a final target. And I couldn't find any literature on the basic science on this, but my understanding is that the axons are going to want to grow, and once the nerve transection has occurred, the axons are stimulated to grow forward. And if they don't find their target, they'll just continue to grow and form a scar neuroma, and this will cause pain. But potentially, if they have a target, now they have a sort of a reason to stop receiving that stimulus to grow. And just basically the way it's done is that the neuromas are resected back to healthy fascicles, and then the fascicles are coapted or connected to distal motor branches within the muscle. They dissect out the muscle and find distal branches and attach a large parent nerve to a smaller distal muscle motor branch. In these cases, 95% of the nerves went on to produce EMG signal in the recipient muscle. These sound to be relatively involved surgeries and complicated. These were specifically for control of a smart prosthetic, which is why they needed to follow this choreographed way of doing this. This is a diagram of how it's done, just how I mentioned. And here's some data on that. Here's from 2014, where they looked at 35 patients, and approximately 90% of them were pain-free at the latest follow-up. So seems to be miraculously helpful for stump neuroma pain, and that's targeted muscle reinnervation. Then more recently, there's been this concept by, both of these are from plastic surgery groups primarily, but there's this new concept of regenerative peripheral nerve interface, where this was described back in 2011 in animal models. It's similar to TMR, and it was described again for control of prosthetic devices, but it involves harvesting a free muscle graft, non-vascularized free muscle graft, and the distal nerve or fascicle of the nerve is actually buried into the free muscle graft. Then the tissue is all closed over it, and the free muscle graft is allowed to revascularize. And they've shown in animals that it does revascularize, and that the nerve does innervate that small muscle graft via EMG, they've found. So here are two clinical publications, one from 2016 that reviewed 16 patients and saw a 71% reduction in pain, with the majority of patients reducing analgesics. This is a plastics article. Here's an article from, I believe, also the plastics literature that compared 45 patients undergoing RP&I. This is actually a recent publication, 2019, versus 45 not. In the patients who did not undergo RP&I at the time of amputation, they saw 13% of these patients forming a symptomatic neuroma, and I believe they followed them for 2 or 3 years. In the RPNI group, they saw 0 symptomatic neuromas form. So there's something there's something about putting the nerve into muscle, giving it a target that prevents this neuroma formation. And it seems to be, it's an exciting thing for people who are involved in taking care of amputees, because these patients are really encumbered by this neuropathic pain. I know, spoke to Dr. Belsberg at Hopkins. I know that he's involved in doing this at that institution. Here at this institution, I believe it's the plastic surgeons who are doing this, and we've seen some of their cases at the nerve conference every other Monday every other month. So here's just an example of that. Here's a patient, an amputee. This is probably done at the time of amputation with a free muscle transfer around the nerve ending. You can see where it's sutured here and here in the middle of the muscle. This is done prophylactically. I actually spoke to this scientist, Stephen Kemp. He's at the University of Michigan. That's where a lot of this research has been done. And also the TMR research was done mostly by military groups because a lot of it was funded by the DoD from grants stemming from, conflicts in Iraq, Afghanistan, and that funded a lot of research for amputees, and that's sort of where all this came from. But this new one, RPNI, is being touted in Michigan. We see this name a lot: Kerry Kubiak and Stephen Kemp, along with the others. So, why is it so effective? It's not fully elucidated yet, and I'm looking into that. And then the axons. Well, I'm looking into that by research-wise, and literature review, and I've also reached out to Stephen Kemp, and we've been in contact about some prior work. Yeah. So future directions. That's basically everything I wanted to go over. And the future directions in nerve research, if anyone is interested, is how can we bring these second generation conduits into certain clinical projects? Clearly it works. Would it be helpful to have? We know how to isolate and expand Schwann cells. We know how to load the conduits with Schwann cells. Can we do all of this? We need to try in the lab first loading human Schwann cells into these conduits, which is our proposed experiment in the upcoming year, which we do have funding for. We're looking for a postdoc and research assistant. If you know anyone, please let me know. I'm sending out some email feelers to see if we can find either of these people. The other thing that we'd like to see is, can we load a decellularized nerve? So that's the axogen nerves. Can these be loaded with Schwann cells? If so, potentially this would be a very helpful thing. So then clinically, I talked about the clinical trial that's ongoing. And the other thing we want to look at is the use of Schwann cell exosomes. So is there any kind of signaling molecule that we can place at the repair site that may stimulate Schwann cells to migrate there? Because by themselves, they have a limited migratory capacity, and they really are the key to allowing axons to grow through a repair site. So that's everything, and I appreciate everyone's time.